Just like any other system, having a strong knowledge base on your anatomy physiology is important. So for our pregnant women, we know that there's going to be an increase in hormones. Specifically, all these hormone changes will have the effect on just about every major body system. Some of the big key players that, in terms of hormones that we are discussing, is estradiol, progesterone, and of course the pregnancy hormone, the HCG. That will drive the majority of these changes, both with the majority being endocrine and metabolic changes. In terms of cardiovascular changes, you're going to have an increase in erythrocyte mass and plasma volume, and reason for that is now we're starting to get more real estate in our women, in terms of now that you're going to have a growing fetus, you're going to need to have everything working a little bit harder, and of course needs to be much stronger in order to get to the fetus and the surrounding tissues. Your cardiac output will increase, and then the systemic vascular resistance and pressure will fall. If you think about it this way, with all the vessels, and then with the growing fetus, things start to kind of put more pressure on these systems, on the vasculature. So then that was what caused the systemic vascular resistance and the pressure to fall. So musculoskeletal changes, of course, we're going to have weight gain, and in just a little bit we'll talk about what type of weight gain that we would be expecting based on the size of the patient, on the weight of the patient prior to being pregnant. And of course there's going to be the hormone relaxin. Due to the nature of the fetus and where it grows, of course we're going to have lumbar lordosis. A lot of this stuff, guys, is very common sense if you think about it, if you really break it down this way. And then in the SI joints and pubic symphysis, the ligaments will start to become more lax, especially as our pregnant woman gets closer to term. For breast changes, they will start to enlarge moderately. This stimulates hormones. Of course, there'll be an increase in vascularity and hyperplasia of the glandular tissues. Of course, this is, again, the further along we go, the more this occurs. By the third month of pregnancy, the breast will become more nodular. And then from mid to late pregnancy, this is where colostrum can be expressed. The areola will become darker. There'll be the Montgomery's glands will be more pronounced, and then they'll see more of an increasing visible venous pattern. Now the uterus will become more palpable once the patient reaches 12 to 14 weeks. And this is because it straightens compared to its anteverted position when they're not pregnant. And then we'll start to rise up out of the pelvis. So as the uterus enlarges, it'll start to rotate more to the right to accommodate the rectosigmoid structures, which are on the left side of the pelvis. They'll have more rugated walls and thicker walls of the vagina, and vaginal secretions become more thick, white, and even more profuse. Doing a pelvic exam, looking at the cervix, you're going to look for the Chadwick sign and looking for a mucus plug. Now, in terms of ovaries, generally changes are not noticeable on physical exam. If you think of even doing a pelvic exam on a non-pregnant patient, depending on body morphology, a lot of times you won't even be able to palpate the ovaries. So when you have a patient that first says, "Hey guys, I'm pregnant," the initial prenatal visit, first of all, you want to confirm that the patient's pregnant, and usually start with a urine test, and then you can move on to a blood test. Then you can check quantitative and qualitative. You want to always assess the health status of the mother. So what is our baseline? Just about, it doesn't matter which type of patient you're working with, you always want to get a strong baseline. And that way you can go back to that to check for any changes. And of course, you want to start counseling the mother to ensure a healthy pregnancy. This is where our education is very important. And again, don't ever think that just because it might be common sense to you doesn't necessarily mean that it's common sense to them. So Depending on where you work and the demographics you have, you might have patients that really need to have a little extra counseling or a little more education. Then, of course, with each subsequent visit, you're always going to still assess the health status of the mother, and now you'll start to assess the status of the fetus, and still continue to educate your patients. When it comes to your history taking, just like any other patient, you're going to want to have a very strong health history, especially on intake. So you want to ask about the symptoms of pregnancy. When was their last menses? Any breast tenderness, talking about nausea and vomiting and any type of fatigue. And again, describing, we typically call this morning sickness within the first trimester, but you want to make sure that you continue to assess for these things, because what might be normal for some people may not be, especially on these subsequent visits as they get closer to term. And of course, the increase in frequency of urination, this is very common, and this is due to the hormone HCG. You want to assess maternal concerns and attitudes about pregnancy, because not everybody is happy about being pregnant. So you want to always assess, do kind of from a mental health standpoint, you always want to assess the mother, and then if let's say the baby's father is part of the story here, you always want to assess that, because you want to assess to see how are they feeling about being pregnant. Was this a planned pregnancy, or was this an oops? Did one get past the goalie and here we are? The other thing too to ask is it even desired? Are they planning on carrying this baby to term? So you also want to assess the current state of health by asking questions of nutrition and exercise. This is, of course, especially important to know what is their lifestyle before they found out they got pregnant. Of course, you want to make sure and at least get a history of any smoking or alcohol and drug history. What do they do for a living? And looking for any workplace hazards. So, for example, just for purposes of bringing a point home, do they work in a lab where they're around a lot of chemicals? And of course, assessing their social support and their finances. You want to obtain past OB history. So this includes past pregnancies that also include what type of prenatal and any labor problems that they may have had. So sometimes it can be a little confusing with when you're assessing gravida and para. So gravida is the number of pregnancies the patient has had, whether or not it's been carried to term, and para is how many viable births, usually greater than 20 weeks, has the patient had. Viable births, keep that in mind. So another way of asking this is, how many times have you been pregnant, and how many kids do you have at home? So how many, another way of thinking or trying to remember it is, I have a pair of kids. So para being how many viable births, gravida being how many pregnancies, whether or not it went to term. You want to review birth weights of those prior pregnancies. So, if a patient gained 30 pounds during the last pregnancy, would you expect that maybe they were to gain the same amount? Or at the same time, you want to look for if there was too much weight gained, because maybe due to nutritional status, for example. Of course, review any miscarriages or fetal demises. And of course, you want to approach this very carefully using therapeutic communication. You want to assess just past general medical history. Specifically, we're looking for things like hypertension and diabetes, things that can carry over into pregnancy. You want to assess family history of any congenital diseases. So here we can be looking for and assessing for sickle cell or cystic fibrosis. So something that, if it runs in the family, something that you might want to be to start to observe for and monitor closely during this pregnancy. So to figure out the estimated delivery date, expected date of delivery, EDD, we're going to use Naegele's rule. So this is something you want to know, especially for the final exam. So with Naegele's rule, you're going to take the first date of the last menstrual period. You're going to add 7 days or a week. And then you're going to subtract 3 months from that and add a year. So if you can try to remember this algorithm, you should do fine. So for example, last menstrual cycle of 5/19/08. So what we're going to do is we're going to add a week. So add 7 days. And that's going to go to 5/26. Now we're going to subtract 3 months from that, which is go to 2/26. Then we'll add a year, because what's going to happen? The baby's going to occur in the future, so at least a year. We want to add to that. So by doing that, you'll get an estimated delivery date of 2/26/09. So to review that again, you're going to take the first date of the last menstrual period. And again, this is an estimated or expected date of delivery. You're trying to get a quick ballpark here. So take the first date of the last menstrual period, add 1 week, subtract 3 months, and then add a year. So other ways to verify the expected date of delivery, you can use a Doppler, and that's or the Dopp tone, which would be positive around 10 to 12 weeks. In the fetoscope, you could be heard around 18 weeks, and quick fetal movement around 18 to 24 weeks, and of course you can use ultrasound. Okay, so let's use Naegele's rule to answer this question. The first day of her last menstrual period was 7/11/08. So now we're going to determine her EDD using Naegele's rule. So remember, you're going to take the first day of the last menstrual period. You're going to add 1 week, so 7 days. Subtract 3 months, and then add the year. So if you got 4/18/09, you would be correct. So general inspection for our pregnant women, you're going to, of course, still overall health status. Do they look their stated age? Do they look acute or chronically ill? Checking their emotional state, and then checking their nutritional status. So again, vital signs are important for every patient. Now we want to establish this baseline for our pregnant women. So chronic hypertension is considered to be greater than 140 over greater than 90 before 20 weeks of gestation. To be classified with gestational hypertension if that blood pressure becomes elevated, so greater than 140 over greater than 90 after the 20 weeks of gestation. They can be diagnosed with preeclampsia, and that's with the elevated blood pressure, greater than 140 over greater than 90, after the 20 weeks gestation, and they have protein in the urine. So you guessed it, you definitely want to get a urine dip on these patients. When you're assessing for weight and body mass index, it's important that you educate your patients on the nutritional status, the amount of exercise that would be safe for this patient. And again, a lot of this has to do, especially when it comes to exercise, of what kind of lifestyle did they had before. Now, if they're very healthy in terms of eating well and exercising quite a bit, then they can potentially carry that over into their pregnancy, whereas now is not necessarily the time to get into an extensive workout routine if it's something that was not part of their normal routine before. So if their baseline body mass index is less than 19.8, then you're going to expect that they're going to gain between 28 to 40 pounds throughout their pregnancy. If they had a quote-unquote normal body mass index, 19.9 to 26, they're going to be expected to, and from a healthy perspective, gain 25 to 35 pounds. If they have a higher BMI, 26.1 to 29, you would recommend that they would gain 15 to 25 pounds in order to be considered healthy. And then if they were obese prior to pregnancy at initial intake, so BMI of greater than 29, then less than 15 pounds to have gained would be recommended. Now again, this is a recommendation. This doesn't necessarily mean what happens. So this is where, again, education is super important. So if you give them the recommendation of saying they're going to gain between, let's say, 25 to 35 pounds, you're hoping that they're not going to be gaining, 40 plus pounds. And again, there's a lot of other factors that go into it, but starting with strong nutritional and exercise education is super important. So looking at the head, look for mask of pregnancy and any type of edema. The hair often will become more dry and even thin. The eyes, you want to examine the conjunctiva and look for any pallor. So for example, a pallor might mean anemia. So again, with the erythrocyte count in the plasma levels to start to rise, you're not expecting anemia. However, if you do see anemia, this is something you want to observe for. In the nose, looking for any edema that might cause some congestion. However, you can tell your patient that's normal. You're going to examine the mouth. So any periodontal disease is common in pregnancy. Now, however, doing a strong assessment at the first intake, the first prenatal visit, to see, again, what's the baseline. Because, again, if they have, say, periodontal diseases going into this, their nutritional status might also be questioned. Patients will often complain of shortness of breath, and that's normal. Again, shortness of breath versus distress, there's a fine line between that. I'll take a step back on that one. However, sometimes if having their respirations might increase a little bit, that, depending on where they are in their pregnancy, could be potentially normal, but it's something you want to assess. So make sure you're getting your oxygen saturation, and of course making sure the patient's not in any distress. In the heart, you want to listen for any venous hums, and those are common in pregnancy. And of course, in the breast, as we already mentioned, the changes that are likely to occur, but you do want to look for any symmetry and color. And again, veins are often very prominent, again, the longer they go into term. When you're looking at the abdomen, looking for any scars from potentially, if, say, they had previous C-sections, for example. Striae or stretch marks are normal, and of course the linea nigra, which is that the darker, usually brown line from the umbilicus down to the pubic symphysis, is normal. You're going to palpate around the abdominal organs for any masses, and palpating the uterus. So again, fetal movements can be usually felt by you, the examiner, around 24 weeks. And then contraction can also be palpated by the examiner at this point too. When you're measuring fundal height, a great way to remember this is usually from 20 weeks to about 32 weeks. The fundal height in centimeters is approximately the number of weeks of gestation. So that's a good way to remember. I'll show you. Your book has a good picture, and I'll show you one here momentarily as well. Again, and fundal height, though, is from the superior portion of the pubic symphysis to the top of the fundus. So again, you want to make sure that you're able to palpate accordingly. When you're auscultating, the fetal heart rate from about 18 weeks with the Doppler or the fetoscope from 18 weeks. Now you're going to expect that the fetal heart rate will be in the 150s to 160s approximately during the first few weeks of pregnancy, and then once you can start to hear them. And then they'll start to go down to the 120s, 140s by term. So you think about what would be the normal heart rate of a newborn. That's what it should be about as it gets closer to term. Here's a good question for you. A pregnant patient at 8 weeks gestation presents to the clinic for her routine prenatal check. She's excited and wants to hear the fetus's heartbeat. Now, using the Doptone to listen to midline just below the umbilicus, a student shadowing you finds a heart rate of 88. Now, you suspect this is a maternal heart rate. So which of the following facts leads you to this conclusion? Normal fetal heart rate at this gestation, 150 to 160. Remember, the patient is at 8 weeks gestation. The pregnancy is too early to auscultate a fetal heartbeat. The student is listening too high on the abdomen for this early gestation, or D, all of the above. If you answered D, all of the above, you'd be correct, as the normal fetal heart rate at this gestation is 150 to 160. It's too early for this person, because usually at 10 weeks is the earliest you can hear the fetal heart rate. Student listening too high to the abdomen at this early gestation, because if you remember the uterus is in the pelvis until about 12 to 14 weeks. So the student's listening a little too high. And here's that figure that I was talking to you about. As you see, the fundal height is in the pelvis from the 12 to 14 weeks, and then it starts to move its way up. And again, remember how you can measure, making sure you're palpating the fundal height, and that can help you with the approximate in centimeters how far along in their gestation that they are. When it comes to Leopold's maneuver, this is a systematic way of being able to figure out the position of the fetus. So here's your first maneuver, followed by your second maneuver, and third maneuver, and fourth maneuver. So this is really, again, not only to be able to, the systematic way to figure out the position of the fetus, also to see if you needed to move the fetus. Now again, this is a very, this is a learned skill. So if this is, you're going to be going into OB as a practitioner, this is something that you want to make sure that you get proper training on. But in terms of figuring out the position, why is this important? Well, we don't want our babies to come out breech. So as we get closer to term, this helps you figure out if the baby would be coming in the, or could be vaginally delivered in the correct position. The genitalia, you want to examine for any previous episiotomy or perineal laceration scars from prior deliveries. When you're assessing the anus, note any hemorrhoids, fissures, or warts that might be present. You can have the patient bear down to look for any rectoceles or cystoceles. If you're doing a speculum exam, so a pelvic exam, you want to note the cervix color, the consistency of the cervix, because of course we know that the softness of the cervix during pregnancy is called Chadwick's sign. And why does the cervix soften up? Because the further along you get, you're expecting to deliver this baby, so they're going to have to, the cervix will start to soften, and then of course the shape of the cervix. You can obtain a pap smear and an STD cultures. Doing the bimanual exam, same way you do it as you did with our standardized patients during immersion. Placing 2 fingers inside of the vagina and then palpating the cervix. And then you can use the other hand on the low abdomen. And in between the hands and the uterus, you can feel for the uterus and adnexal areas. So here you want to assess how long the cervix is, so that during labor, the thinning of the cervix can be estimated. Again, all estimation. Further along they get, you can assess if the external and internal os is open or closed. And in the term patients, again, assessing the station of the presenting part. So how inferior the presenting part is compared to the ischial spines. You want to examine the extremities for any varicose veins and edema. Of course, still you can check reflexes. Doing the lab work that would consist of CBC, blood typing, what type of blood they have, hepatitis panel, HIV testing, syphilis testing, urinalysis and culture, pap smear, and chlamydia and gonorrhea cultures, which also come from the urine. And then the follow-up visits from that, the initial visit, you still want to test the urine for glucose, because here we're looking for gestational diabetes. Looking for protein in the urine, because we knew that any protein in the urine plus an increase in blood pressure greater than 140 over greater than 90 at 20 weeks gestation would include a diagnosis of preeclampsia. And of course, we're looking for any white blood cells, as we would anybody else, for white or excuse me, for infection. So in terms of frequency of these visits, of course, you want the first visit during the first trimester for your full history and physical, and lab work, so you can get a really strong baseline. During the second trimester and then into the third trimester, so up until about 32 weeks, the patient will be seen monthly. Then from 32 weeks to 36 weeks, the patient seen every 2 weeks. And then from 36 weeks up until delivery, the patient should be seen weekly. Of course, depending on any other comorbidities or high-risk pregnancies, this might change, but this is a good baseline in terms of knowledge for a normal, healthy, pregnant woman. During these visits, you can start to screen for genetics, do genetic screening from 15 to 18 weeks. You can start ultrasounds about 20 weeks, doing your diabetes screenings 24 to 28 weeks, and then checking for group B strep, as this is the #1 cause for neonatal meningitis. You also want to perform, see what their RH status is, because a problem with the RH negative anemia and urinary tract infections can be treated. So just in general, in terms of education for these patients, same thing: nutrition, weight gain, how much would be recommended based on their BMI, what type of exercise and how much. Talking about smoking cessation, alcohol, and illicit drug use, if present, because if you did a very good, strong history and physical for your baseline visit, you still would want to follow up with these if anything was prominent there. Also screening for domestic violence and checking for immunization status.